Hi everyone, in this video I'll be discussing anti-cancer drug. So before I start this anti-cancer therapy, what is a cancer? It's nothing but an abnormal proliferation of cells. Now the problem is when we use anti-cancer drugs, we have the normal cells which are also dividing. So the normal cells also multiply. So these are the normal cells. Yes. And we have the cancer cells. They also multiply. They also multiply. Now, what is the basic difference between the two? If normal cells also multiply, cancer cells also multiply. What is the difference? The cancer cells, they have uncontrolled division. So the proliferation or division is uncontrolled, whereas the normal cells have controlled division. So that is the reason the cancer cells are not obeying the body's rule. They are obeying their own rule. They are multiplying without any control, uncontrolled division. So any cancer, we have three modalities of treatment. So cancer, there are three modalities of treatment basically. You can remove the cancer by surgery. So for example, a breast cancer, do the surgery, remove it. Or we can give radiation, and that is called radiotherapy. The third important thing, we can give drugs and kill the cancer cells. So that is called the chemotherapy. So basically, we have three modality of treatment: surgically, or give radiation, or we have something called chemotherapy, and that chemotherapy is called the anti-cancer drugs. Anti-cancer drugs. Yes. But when we are using an anti-cancer drug, what is the problem? When we use an anti-cancer drug, the anti-cancer drug doesn't differentiate which is normal and which is abnormal. So the anti-cancer drugs will target both the cancer cell as well as normal cell. So it will inhibit the division of both. The cancer cell also affected, normal cells are also affected because it doesn't know which is the cancer cell, which is the normal cell. So the normal cells are also going to be affected. So when we use an anti-cancer drug, there are certain common adverse effects we come across. Common adverse effect of anti-cancer drug, which is commonly asked in your exam. Common adverse effect of anti-cancer drug. Let us start one by one. Now let us go from head to toe. What happens? The hair follicle also divides. The hair will grow. If you use an anti-cancer drug, patient will have loss of hair, what we call it as alopecia. Now the question is alopecia reversible or irreversible? So reversible, so no need to worry for that. So reversible for that, no problem. The second problem is in the mouth. When we are chewing, and every day the cells will die and they regenerate. The cells will die and they regenerate. Now if I use an anti-cancer drug, they don't regenerate and the mucosa will get inflamed, and we call it as mucositis. So whenever we use anti-cancer drug or we use radiation, there is a chance of mucositis. Now is there any drug which can prevent that? So to prevent this, we use a drug, and the drug name is called palifermin. Sir, what is palifermin? Palifermin is called as keratinocyte growth factor. So palifermin is called as keratinocyte growth factor. So that can prevent that problem. So when you use an anti-cancer drug, we get mucositis, we use palifermin. The third important problem, the head is done, the mouth is done. Now come to the bone marrow. Now the bone marrow, we have the cells which always multiply in our bone marrow, the RBC, WBC, platelet. When I use an anti-cancer drug, the anti-cancer drugs will stop the multiplication there. So that is called bone marrow suppression. Bone marrow suppression. So the drugs will suppress the bone marrow. What is the problem if bone marrow is suppressed? The immunity comes down. When the immunity comes down, patient is prone for opportunistic infection. That is the advantage or disadvantage. Is there any advantage with bone marrow suppression? Yes. Where? In autoimmune disorder, in organ transplants. So we have discussed that in a separate topic called immunomodulators. But the major drawback is bone marrow suppression. What happens if bone marrow is suppressed? There is decrease in WBC. So is there any way to overcome this decrease in WBC? There are two important things. We have GM, CSF analog. We have granulocyte, monocyte, colony stimulating factor analog, and the name of it is called as sargramostim. So you read the name, it is a granulocyte monocyte stimulator. Similarly, we have one more that is called molgramostim. So these, when we use it, they stimulate the bone marrow to produce more and more WBC. Similar to that, we have GCSF. G stands for granulocyte colony stimulating factor analog. And the name of it is called as filgrastim. So granulocyte stimulator, GCSF. So if you add PEG for that, this becomes longer acting. It is called as pegfilgrastim. Then we have one more grastim that is called linograstim. These are used whenever the WBC comes down or the neutrophil comes down. Recently in one of the exams that asked, patient was on cancer therapy, the WBC became 1000. What do you give? The one of the option was filgrastim. So any of this you can give it and correct it. The next problem is there is decrease in RBC. So RBC production is decreased. So what happens if RBC production decreases? If the RBC production decreases, patient will develop anemia. So how do we correct this? We have a stimulator of bone marrow to produce more RBC, that is called erythropoietin. So erythropoietin is the natural one. So we have a preparation of erythropoietin. The name is called darbepoetin. So read them, they end with poietin. And we have epoietin. That also ends with poietin. These are used to treat anemia. These are used to treat anemia due to anti-cancer drugs. Darbepoetin and epoietin. One more blood component that decreases is platelet. So that is called thrombocytopenia. Now how do I correct it? We have an interleukin 11 analog for that. And the name of that analog is Oprel. You know April, this is Oprel. Oprel Vaken. It is called as Oprel Vaken. It's an interleukin 11 analog. So that will correct that. So we know how to manage the bone marrow suppression, WBC, RBC and platelet. But there are certain drugs which don't affect the bone marrow. We call them as bone marrow sparing anti-cancer drug. Bone marrow sparing means they don't suppress the bone marrow, they will only kill the cancer cells. The name is vincristine. Its name is vincristine. And then we have bleomycin. And one more is L-asparginase. So these are bone marrow sparing anti-cancer drugs. So we are done with the alopecia, mucositis and bone marrow suppression, and we have some bone marrow sparing drugs. So once we are done with that, let us come to one more important aspect, the GAT. So what happens in GAT? When we use the drugs, the cells in the GAT are also going to be killed. They release serotonin and they can also cause vomiting. So patients may develop something called early CINV. Sir, what is CINV? CINV stands for chemotherapy induced nausea and vomiting. So if it is occurring within 24 hours of starting chemotherapy, we call it as early. And the drug of choice for that is 5-HT3 antagonist, 5-HT3 antagonist, and what do they end with? All these drugs end with cetrol. So this was the question asked in recent exam. Early CNV, what is the drug of choice? 5-HT3 antagonist. Examples let me give. Ondansetron. Then one more longer acting is palonosetron. So simply remember, early CNV, the drugs are cetron drugs. One more complication in GAT is the late CANV. What do you mean by late, sir? If it is happening between 1 to 5 days of starting chemotherapy, then the drug of choice is, what is the drug of choice? They are neurokinin 1 receptor antagonist. Neurokinin 1 receptor antagonist, and they end with pitant. Example is apripitant. For that, if you add force, it becomes force apripitant. Then we have netopitant and rolapitant. So these are the pitant drugs for late CANV. So nowadays, when you are starting a cancer therapy, what the oncologist will do before starting cancer therapy, he will start the antiemetics. So what we do is we start the antiemetic before only. So prior to chemotherapy, to avoid vomiting, prior to chemotherapy, we start antiemetic drugs. The combination is like this. We add 5-HT3 blocker plus neurokinin 1 receptor antagonist, and we add steroids also. So steroids decrease the inflammatory process, for example dexamethasone. So this combination is best to prevent CANV. Best combination for CANV, that is chemotherapy induced nausea and vomiting. That's the best combination. So I told you the nausea and vomiting part of this, but in GAT there is one more problem. Not only nausea and vomiting, patient will also develop diarrhea due to the drugs. Diarrhea due to the drugs. Now how do you manage? Most of the diarrhea is not because of infection, it is because of the drug adverse effect. Patient will have diarrhea. It's a secret diarrhea. The drug of choice for cancer-induced diarrhea is by the name loperamide. Loperamide, again this is a important question for MCQ. So common adverse effect is commonly asked in an exam, don't worry. Now once GAT is done, what is the other system we need to understand? It is the gonads. In the male, you know that there is spermatogenesis, and if you stop the multiplication of the cells, the patient will have oligospermia. And also in female, the oogenesis will not happen. Female, there is decrease in oogenesis, and it will lead to infertility. So the anti-cancer therapy can lead to infertility. What about the use in pregnant women? Can you use anti-cancer drug in pregnant women? Absolutely no, because the fetal cells have to divide. If you use an anti-cancer drug, fetal cells will not divide, and that will lead to teratogenicity. So they are teratogenic drugs. So anti-cancer drugs are highly teratogenic drugs. Highly teratogenic drugs. So these are contraindicated in pregnant women. Don't give it. So we are done with the GAT, then we are done with the gonads. Next, the problem is when you give radiotherapy, there is something called radiosensitization. So we can prevent that radiosensitization. We have a drug called amifostine, it is called as radioprotector. The radioprotector drug is called amifostine. So amifostine, it decreases radiosensitization, decreases radio sensitization which occurs during radiotherapy. I told you there are three modalities of treatment. One is radiotherapy. Another problem what happens is when you are killing a leukemia or a lymphoma, there are plenty of WBCs, and when you kill them, there is release of purine. What is the end product of purine? Is uric acid. So patient will have hyperuricemia, and the problem is called tumor lysis syndrome. So when the tumor lysis occurs, purine are released and they are metabolized to uric acid. So patient will have hyperuricemia. So hyperuricemia, what is the best drug? The treatment is started with allopurinol. So it is the best drug to treat and prevent. If there is resistant, then the overall drug of choice will be rasburicase. So rasburicase is the overall drug of choice for tumor lysis syndrome to overcome the hyperuricemia, because this rasburicase can convert uric acid immediately into allantoin, which is water soluble. So if the uric acid is too high, it can convert immediately. But if you give allopurinol only blocks synthesis. Once the uric acid is already high, it cannot bring the uric acid down. So the only drug which can bring the uric acid down is rasburicase. That's why it is the overall drug of choice. So we understood the tumor lysis syndrome. Now one more complication, not because of the drug. Sometimes in malignancy, there is something called hypercalcemia of malignancy. Suddenly the calcium shoots up. Hypercalcemia of malignancy. Now, how do you manage that? How do we bring down the calcium down? So, to bring down, the best drugs are calcitonin. Calcitonin can be given, or a loop diuretic can be added, furosemide, or we can use a bisphosphonate. The name is called zoledronate. Zoledronate is not going to work fast. It is slow acting. But the faster acting drugs are these two. So this is how we manage the problems of the common anti-cancer therapy problems, adverse effect. So let me repeat again. Alopecia reversible, mucositis paliform in bone marrow, we have Grastim, we have Gramostim, or we have Poitins or Oprelvecin. There are some bone marrow sparing drugs. Early CANV, 5HT3 blocker, Cetron. Late CANV, we have pitants. The best combination is 5HT3 blocker plus pitant plus dexamethasone. Diarrhea, you can give loperamide, the drug of choice. Then infertility is a problem. Don't give it in pregnancy, it is highly teratogenic. Tumor lysis syndrome, the drug of choice is rasburicase. You can also use allopurinol to treat and prevent. But the best is rasburicase, and we have a radioprotector drug called amifostine. Hypercalcemia malignancy, the fast-acting drugs are calcitonin, furosemide, and we have a slow-acting one, they are bisphosphonate. So the questions are being asked on this mainly. Please consider that. Once we are done with this, let us understand the anti-cancer drugs. Now these anti-cancer drugs we will discuss in three headings. The drugs which are cytotoxic drugs. Cytotoxic drugs, and we also use hormonal agents. Hormonal agents, and we have something called targeted therapy. Now the problem with cytotoxic drugs we just discussed, they don't target only cancer cell, they will target a normal cell. That's why so many adverse effects. Targeted therapy, they will target mainly the cancer cell. they spare the normal cells. So nowadays the focus is mainly on targeted therapy. And hormonal agents we have discussed in endocrine, I will just brush up again in this anti-cancer therapy. So let us start our journey. Cytotoxic drugs, also called as the non-targeted drugs. So let us start our journey. Cytotoxic drugs which are non-targeted therapies, or we call it as the non-targeted drugs. Okay, yes, sir. In that we have two types. The one which act on the cell cycle, which are not specific, non-specific, and we have cell cycle specific anti-cancer drug. Sir, what do you mean by that? What do you mean by cell cycle? Now you already know this in physiology as well as pathology. Some of the cells are in G0, they don't multiply like brain and heart. We have normally the G1 phase. S means synthesis of DNA. Then we have the G2 phase, and then M phase where it is mitosis, and again we come back to the G1 phase. So everywhere, why the nature has given these phases? To check whether the cell is normal or abnormal. If it is abnormal, you delete it. Now in cancers, what happens? These checkpoints are not there, so the cancer cells keep on replicating or multiplying. Now certain drugs act on the cell cycle. For example, the G1S phase, the drug which acts is etoposide. The drugs which interfere with synthesis of DNA, they are called as anti-metabolites. Anti-metabolites. In anti-metabolites, we have the drugs which are given as fake ones. We give a fake purine, they are called as purine antagonist. We give fake pyrimidine, they are called as pyrimidine antagonist. Then we use the folate antagonist, and the major one is called as, you all know, methotrexate, and a drug called hydroxyurea. Yes, so these are the drugs which act on S phase. Now there are certain drugs which act on G2M phase. We have an anti-cancer antibiotic, the name is called bleomycin. And we have the drugs which inhibit topoisomerase. So DNA topoisomerase 1 and 2 inhibitors. So we have the drug by the name bleomycin and the drugs which inhibit DNA topoisomerase 1 and 2. Now mitosis, what do you mean by mitosis? Cell division. So during cell division there are certain things called microtubules. I will just give an example here. This is the cell and there is a centromere here and there are DNA. I'm just giving an example here. So there are microtubules like this. So the dotted one which I have written, they are microtubules. So they will contract, relax, and they pull the DNA to the opposite fold and the cell will divide like this. Now these drugs will interfere with microtubules and damage them. And they act on M phase, they are called as microtubule damaging agents. Microtubule damaging agents. So what are these drugs? Let me introduce them. You can remember by the mnemonic wheat drugs. Wheat. V stands for the vinca alkaloids. That means they are obtained from the plant. Then we have a drug called estramustin. Estramustin is used in prostate cancer, we'll discuss, don't worry. Then we have apothiols. They are called as apothiols, which is used in breast cancer, and eribulin, and we have T for taxanes. So these are cell cycle specific drugs. So G1S, it is etoposide, S, antimetabolites, G2M, deomycin and DNA topoisomerase inhibitors, and M phase microtubule damaging agents. So we will discuss them later. Okay, so we'll be discussing cell cycle non-specific drug here. So cell cycle non-specific drugs. So in that we have 4 headings. First we will be discussing the DNA damaging drugs or DNA alkylating agents. Then we will be discussing a group called platinum compounds. Then we will be discussing anti-cancer antibiotics. And the last one we'll be discussing is miscellaneous. So we'll be discussing under this heading. Let us start our journey. So the first one is DNA alkylating agents. DNA alkylating agents. So what do they do? As the name suggests, let us understand the mechanism of action. Now these drugs when we give, they enter the cell. So this is the cell. They enter the cell. What happens there? They will produce highly reactive carbonium ions. Carbonium ions are produced. So what do? These will come and sit at a place of DNA. So this is the DNA. In the DNA there is a point called N7 guanine residue. So this is the place where they come and bind. Now once they bind, what do? They will cause cross pairing. They cause cross pairing and mismatch in the DNA. So cross pairing and mismatch in the DNA. So that means usually we know that adenine with thymidine, then guanine with cytosine. So cross pairing means adenine with cytosine, guanine with thymidine. So that will happen. Now what happens if the DNA is mismatched and cross pair? That will lead to DNA damage. So when the DNA is damaged, there are 2 fate. Either the cell will die, so there is cell death, or sometimes what happens, the damaged DNA can proliferate and the patient may have secondary cancers. So the damaged DNA may proliferate, the cells may proliferate, leading to secondary cancers. Remember, anti-cancer drugs, they themselves can cause a secondary cancer, that is also possible. So there is DNA damage. This is the mechanism of action. Let me repeat again. Drugs enter the cancer cell. They form a highly reactive carbonium ions. They bind to N7 guanine residue where they alkylate the DNA. There is cross pairing and mismatching. There is DNA damage and cell death. Or these damaged DNA can proliferate and can lead to secondary cancer also. But cancer cells are also intelligent. They want to survive. So this is the cancer cell. Now if the drug enters, now what do? They have a pump which can throw it out. And that pump name is called P-glycoprotein. It is an efflux pump. It's an efflux pump which can throw it out. Now this is responsible for drug resistance in cancer cells. Drug resistance by cancer cells is due to the existence of P-glycoprotein. So we have discussed that in general pharma also. Now very beautiful. When the drug enters inside, the cancer cells produce more P-glycoprotein which will throw it out and the cancer is not killed. That's the reason when we are treating nowadays cancer with drugs, we have to give them in combination. We have to give multiple drugs, not a single drug. Single drugs are not so much effective nowadays. We use the regimens for that. We use 4 drugs, 5 drugs like that. Only for few cancer we use single drug, but otherwise, like antimicrobial therapy, we have to use combination therapies here. So let us start our journey. What are the drugs which are called as DNA alkylating agents? The number one and the first one is called meclorethamine. So the first anti-cancer drug is called as meclorethamine. The problem with meclorethamine is it is known to produce skin blister. Skin blister, that is the adverse effect. And it was used to treat a condition called Hodgkin's lymphoma. Hodgkin's lymphoma. And I told you we don't use single drug for cancer therapy because we are worried about resistance. So we used a regimen called MOP regimen. MOP. Sir, what is MOP for? M for meclorethamine, O for oncovin. Oncovin, it has another name called vincristine. So onco for cancer, vin for vincristine. So a drug for cancer, oncovin. Then Phe for prednisolone. Prednisolone is a steroid, and we have discussed in corticosteroid they can also be used in treatment of lymphoma and leukemia. Then procarbazine. So that is a regimen called MOP regimen, what we use to treat cancer therapy. So single drug will not work. Nowadays this regimen is not used because meclorethamine causes skin blisters. So we use a new regimen for this. What is a new regimen for Hodgkin's lymphoma? It is called as ABVD regimen. It is called as ABVD. So A for adriamycin. Adriamycin is also called by another name, that is doxorubicin. It is also called as hydroxydonorubicin. So one drug has this much name. It is also called as adriamycin, doxorubicin, also called as hydroxydonorubicin. Okay. B for bleomycin. And remember here V is not vincristine, it is vinblastine. It is called as vinblastine. And D for dacarbazine. I think you have studied that in pathology also, the regimens for Hodgkin's lymphoma. So that is about the first anti-cancer drug that was used, meclorethamine, but because of adverse effect we are not using it nowadays. So the other DNA alkylating agent what we are going to discuss is called melphalan. It is called as melphalan. Read the name. It is called as melphalan. So since it starts with melphalan, it is also used to treat multiple myeloma. So M for, you can see the M multiple, and one more M, myeloma. It is used for multiple myeloma. Then we have a drug by the name busulfan. Busulfan is used to treat chronic myeloid leukemia, CML. It is used for CML, but there is some adverse effect with this drug. Commonly asked in the exam, too important is it causes lung fibrosis. We call it as pulmonary fibrosis. Can you tell me an antiarrhythmic drug which causes the pulmonary fibrosis? If you're telling amiodarone, very good, 100% correct. And also it will cause sinusoidal obstruction syndrome in the liver. Sinusoidal obstruction syndrome. These are the two important conditions. So it will cause this problem. It is also called as veno-occlusive disorder of liver. So busulfan can cause sinusoidal obstructions. So once we know the drug busulfan, let us understand one more drug. If you know B, there is one more C, that is called chlorambucil. Now chlorambucil will not affect the myeloid cells, so it will affect only the lymphoid cell. That is why it is considered the oral drug of choice for CLL. So oral drug of choice for CLL, remember C for chlorambucil and busulfan for CML. So chlorambucil will not affect myeloid. That's why we cannot use it in myeloid leukemia. We can use it in lymphoid leukemia. The name is called chlorambucil. We have melphalan, busulfan, chlorambucil. But one beautiful drug for your exam now comes. The name is called cyclophosphamide. It is called as cyclophosphamide. Now cyclophosphamide is a prodrug. It has to be converted into an active form by the enzyme cytochrome 2b6, and that will give rise to 4-hydroxy cyclophosphamide. So let me drag this side. So recently this question came in your exam. Cyclophosphamide metabolism gives rise to what? 4-hydroxy cyclophosphamide, and that will give rise to aldophosphamide. And this is the active one, which will give rise to another active point. What is that? It will give rise to phosphoramide mustard. It is called phosphoramide mustard. So it is called as phosphoramide mustard, and that is the one which produce anti-cancer effect. So anti-cancer effect. Now what does another compound give rise to? That is called acrolein. The name is acrolein. Now acrolein is going to cause a problem, that is hemorrhagic cystitis. So the patient will have pain in the suprapubic region because of hemorrhagic cystitis. Now, is there anything that prevents this? Yes, the drug to prevent and treat this problem, the drug which binds to acrolein, and the name is called Mesna. The name is called Mesna. It is called as mercaptoethane sulfonate. Mesna stands for mercaptoethane sulfonate, which will bind to acrolein and prevents the causation of hemorrhagic cystitis. So the culprit is acrolein, the prevention is by Mesna, and the drug causes hemorrhagic cystitis, very, very common. So we understood the pharmacokinetics of cyclophosphamide. Remember, cyclophosphamide is one of the highly emetogenic drug. It can also induce vomiting too much. Cyclophosphamide. Now, where to use it? What are the uses of cyclophosphamide? Uses. There are two important uses. Number one, since it's an anti-cancer drug, it can cause bone marrow suppression. That means it can suppress immunity. So it can be used as immunosuppressant drug. Now, where do you use it as immunosuppressant drug? It is considered the drug of choice for Wegener's granulomatosis. So there it suppresses the immunity. It is also drug of choice for steroid dependent nephrotic syndrome. I think you have studied in pediatrics. Steroid dependent nephrotic syndrome, the drug of choice is cyclophosphamide. That's the reason why the questions come from this. So these are the conditions. And one more autoimmune disorder what we use is in rheumatoid arthritis, we also use cyclophosphamide, but not a first line drug, we use it later. Next, we use it as mainly an anti-cancer drug, So mainly it is used in a lymphoma called non-Hodgkin's lymphoma. So we call it as NHL, non-Hodgkin's lymphoma. So for this also we use regimens. For example, the regimen name is R-CHOP. It is called as R-CHOP. Sir, what is R for? R stands for a mAb called rituximab. So rituximab blocks CD factor, that is CD20. C is the drug which we are discussing, that is cyclophosphamide. H for hydroxy donorubicin. Now, can you tell me the name now? What is other name for hydroxy donorubicin? It is also called as doxorubicin, also called as adriamycin. Say. O stands for oncovin. Can you tell me what is oncovin for? It is vincristine. And P for prednisolone. P for prednisolone. Again, see the regimens have been given a name and we use multiple drugs. Cyclophosphamide is also used as an anti-cancer drug for another cancer called breast cancer. In breast cancer, we use a regimen called CMF. Sir, what is C for? Yes, that is cyclophosphamide. What is M for? The drug by the name methotrexate. And F stands for 5-fluorouracil. So it is nothing but 5-fluorouracil. So this is the regimens. We use it for cyclophosphamide in the treatment of breast cancer. Okay, so once we are knowing about cyclophosphamide, let us understand a drug which similarly sounds like that is called ifosfamide. Ifosfamide, the advantage is it causes less vomiting, it is less hematogenic, but the disadvantage of this is it is causing more hemorrhagic cystitis, more chance of hemorrhagic cystitis, and also it is more neurotoxic. The reason why it is neurotoxic is because it produces a metabolite called chloroacetaldehyde, and that's the reason it is highly neurotoxic drugs. So it produces metabolite called chloroacetaldehyde, that's why it is more neurotoxic drug, and that is ifosfamide. Now, please concentrate on cyclophosphamide, very commonly asked in the exam. You should never miss that drug, cyclophosphamide. Then we have another group of drugs by the name nitrosoureas. They are called as nitrosoureas and they end with mustin. So we have the drug by the name carmustin. Then we have lomustine and samustin. So they end with mustin. What is the specialty of these drugs? These are highly lipid soluble. They are highly lipid soluble. So one important advantage is they can cross the blood-brain barrier easily. So they can be used to treat the brain tumors. They are used in the management of brain tumors. Now on the disadvantages, they can easily cross the bone marrow, and in the bone marrow they can produce sustained neutropenia. Sustained neutropenia can be seen with these drugs, mustin drugs. So this was one of the recently asked exam question. So then we have a drug by the name streptozocin. The name of the drug is called streptozocin. So streptozocin gets attracted to the pancreas. So it can go and damage the pancreas. Pancreas is damaged by this. So we use it in experiments. Suppose you want to make a rat diabetic, you have to destroy the pancreas. What do we give? We give streptozocin. It will damage the pancreas of the rat and it will become a diabetic rat. So that is why we use it in animal experiment. So where do you use it? To induce diabetes in rats. So in animal experiment we use it. In certain cancers also we use that. Now another drugs, the name of the drug is procarbazine. Procarbazine specialty is it's a MAVO inhibitor. So it inhibits the enzyme MAVO, and it should not be consumed with alcohol. It can cause disulfiram like reaction. Disulfiram like reaction, and it is also known to produce secondary leukemias. So the drug is called procarbazine. If you know procarbazine, similar to procarbazine, we have a drug dacarbazine. So these carbazine drugs, they are used mainly to treat two important conditions, Hodgkin's lymphoma as well as non-Hodgkin's lymphoma. You can see that these are there in the regimen. If you check, you will see that. So they are present in the regimens, procarbazine and dacarbazine. So the last drug in this category, what we are going to discuss is temozolomide. So temozolomide, it is used to treat a brain tumor, and that is called glioblastoma multiforme. Right. So these are the DNA alkylating agent, very much important for your exams. There are others also not so much important for you, for example, thiotepa and all those things. What is high yielding that we have discussed here? In this video, let me conclude the things. Now, any cancer, we have three modalities of treatment. One is surgery, one is radiotherapy, and one is the chemotherapy, that is anti-cancer drug. Anti-cancer drugs, we have cytotoxic drugs, hormonal agents, and we have the target therapy. Cytotoxic drugs, they can affect the normal cells as well as cancer cells. So we have common adverse effect, alopecia, mucositis, bone marrow suppression, nausea and vomiting, diarrhea, infertility, radiosensitization, and tumor lysis syndrome, as well as hypercalcemia malignancy. And we have discussed how to manage that. That is the point where the questions maximally come. Then I told you there are certain drugs which are cell cycle specific, G1S, S, G2M, and mitosis. And then we discussed cell cycle non-specific, 4 important classes, DNA alkylating agent, platinum compounds. Then we have anti-cancer antibiotics and miscellaneous. So in DNA alkylating agents, first drug is meclorithamine. Then we have melphalan, which is used in multiple myeloma, busulfan for CML, chlorambucil for CLL. Main drug you have to concentrate is cyclophosphamide. It's an immunosuppressant as well as anti-cancer drug, but it causes hemorrhagic cystitis because of acrolein. How do you prevent it? Mesna. Ifosfamide is highly neurotoxic, but also it causes more hemorrhagic cystitis, less vomiting compared to cyclophosphamide. Apart from that, we have temozolomide, which is used in glioblastoma multiforme. So these are the points you have to keep in your mind in this video in short. Thank you all.